Yeah. So my name is Parwise. I'm one of the fifth years based in Salford. Today I've been asked to do general surgery with you guys. So basically cover most of the surgical emergencies that you'll see, be it on placement or exams. We'll try and whiz through as much as possible. Won't be able to do everything, but we will have sessions going over the next few weeks that can fill in the gaps as well. Hold on if this works. So this is a sort of timeline that we've got over this semester. We've got colorectal next week, which will tie in quite nicely to this one. And then going forward, ophthal, pediatric surgery, TNO, ENT and vascular. So do try and attend. We put our most into these sessions, so do try and show up. So for this session, mainly what I'm going to do is try and introduce you guys to abdominal pain. I know there's a lot of you that are preclinical as well, so I'm going to try my best to sort of cater for everyone, and also some of the clinical years as much as I can. We'll go over some surgical terminology and go over some of the common surgical emergencies that you'll see on placement and in exams as well. And then I'll also try and answer any questions that you guys might have, but I'm obviously not a surgeon, so I'll try my best. But do let us know in the chat if you have any questions at the end of the session. We've got about an hour, so I'll try and cover everything, but if not, I do apologize if we run over. So, acute abdominal pain. So we normally define it as sudden onset, severe abdominal pain. Okay, so what this means usually is within the onset of 24 hours. This is quite a narrow definition. So you can see people presenting in a few days or weeks, maybe not weeks, but at least a week, and it can still be counted as acute abdominal pain. But strictly speaking, the acute abdomen is within 24 hours and usually is a surgical emergency, okay? And the best way to think of these things is to look at this diagram. So straight off Geeky Medics, there's a lot of diagrams out there like this as well. But the best piece of advice I can give you is to go and learn this diagram, okay? And I'm not saying that it's necessarily, you should follow it exactly, but it serves as quite a good area of focus when you think of broad differentials, okay? I won't go through every single condition on this, but broadly speaking, what I want to go through is the different areas of the abdomen, okay? And I don't want to go into your anatomy too much previously, but if you have a bit of an idea of this, it really helps when you're looking at patients and exam questions. So obviously there's no one in person, so I'm not going to try and test you guys on your anatomical regions, but you have your two hypochondriums on your right and left, your epigastric area. Going down, we then have our central abdominal area, the two flanks, the two iliac fosses on the sides, and the suprapubic area. Okay. On a general rule of thumb, on the upper side of things, so in the hypochondriac and the epigastric areas, the most important thing to remember is medical causes of abdominal pain. Okay. So exam questions love doing this. They'll present you with a patient who has an MI or a DKA, and it'll be presenting as severe abdominal pain. So the reason I mention this is to keep your differential list broad and not just remember GI pathology as well. Okay. Right upper quadrant pain is pretty much always biliary or hepatic in nature. So always think about gallstones. And then moving across the left side, left upper quadrant pain is quite rare. And it will usually be from a sort of generalized pain that patients point to in the first place. Epigastric pain, most commonly you see with pancreatitis in exam questions, okay? But it can be there, as I said, for MIs and pneumonias. So lower lobe pneumonias is something that's really important to rule out in these sort of questions. And then obviously general gastroenteritis. Moving down on the flanks, the most important thing to sort of remember is renal pathology, okay? So anyone presenting with severe flank pain, it's always important in exams and on the wards, if a consultant asks you, for example, to always do urine dipsticks and urine cultures in older patients as well, okay? Because renal colic is quite common in exam questions and it's quite a common cause of acute pain, okay? Umbilical pain. So this is usually quite non-specific and generalized. Usually it's from when pain starts earlier on. So I don't want to bore you guys with somatic and visceral innervation, but generally most abdominal pain will start in this region. Okay, so for example, appendicitis, which we'll talk about in a second. This is because the actual the viscera over the organ will start to get inflamed first, and then the pain will localize. So generally, central abdominal pain can be quite non-specific, and usually migrates to somewhere else. But the main things to keep in mind are ruptured AAA is the most important thing to remember. Bowel obstruction, colitis, constipation, these sorts of things, and obviously pancreatitis. Moving down, the most important thing to remember is ovarian or gynecological pathology. Okay. So you'll get a lot of questions on the right iliac fossa and ascertaining as to whether that's GI pathology or gynecological. Okay. So as a good rule of thumb in young sort of fertile females, for example, always good to do a pregnancy test with any lower abdominal pain. Even if you think it's appendicitis or you think it's a UTI or diverticulitis, always do a pregnancy test in young females. By young, I mean honestly anywhere from the age of sort of young teenagers to the age of 35, 40 these days as well. Always do a pregnancy test because an ectopic pregnancy is a very severe emergency that needs to be dealt with quickly. So that's rather the reason why I mentioned iliac fossa. And in the suprapubic region, realistically, in terms of exams, usually urinary retention, testicular torsion, or UTIs. But again, a very generalized sort of area for abdominal pain. Now, I know it's a lot of overload going through these things, but I would really recommend you guys go through this diagram and learn it, especially if you're in the early years of your of medical school as well, because it will help you sort of form diagnosis lists. So the key to approaching abdominal pain, some of the older years will probably be saying this a lot, but I'm still going to say it because it's genuinely one of the most important things when you see pain in exam questions. Okay, Socrates will absolutely never fail you. And in general surgery and abdominal pathology, the most important thing will always be sight. Okay, so ascertaining where the actual pain is, asking in histories where is the pain is the most important thing because of the diagram I showed you previously. It helps you form differential lists. It rules things out sometimes, and it's a really good place to start. I'm not going to go through the whole of Socrates because I think we'll do an OSCE session on that later on. But essentially, all of these things should help you form a differential list for some of the conditions that we talk about. Again, I'm not going to bore you with foregut, midgut, and hindgut, but essentially, my point is that anatomical knowledge will really help you find pathology in this region. Examination wise, again, site of pain is the most important. If you're seeing a patient on the ward, for example, or you're in A&E clerking, asking where the pain is, palpating and seeing where it hurts the most is the most important thing of the examination. I'm not going to go through the whole thing, but always look for signs of peritonitis. So rebound tenderness, involuntary guarding. So voluntary guarding, you will see in patients with pain. So if you have a tummy ache, for example, you will voluntary guard. But involuntary guarding is a sign of peritonitis. And a good way to do this is to actually distract the patient while you're examining them. Okay. So if you start talking about something else, you're palpating them and they're in severe pain, that's involuntary guarding. Okay. And this is an acute surgical emergency and we'll pretty much always need a laparotomy, be that in real life or in exams as well. So laparoscopic surgery, because I'm going to mention it so much, I thought it'd be worth going through some of the few things to do with laparoscopic surgery. It's pretty much the norm these days to do everything laparoscopically. And the only caveats are the things that I've listed on the left-hand side. So any form of hemodynamic instability, so hypertension, hypoxia, blood loss, a severe blood loss will always be done open. Okay, so if you see exam questions where patients come in with a BP of 90/40 and they have severe acute abdominal pain, this operation will always be done open for the purpose of exams. Okay. Complexity of case is a bit of a weird one and it's a bit operator dependent, but as a general rule of thumb, the more complex the case, usually it does get open, but everything's transitioning over the years anyway, so I wouldn't worry too much about that as well. Any exam stem of perforation or gut ischemia will always be done open, okay? And that's to assess for gut viability, which is a lot easily done with open operations than it is with laparoscopic, okay? It's easier to perform, obviously, training takes time, and laparoscopic operations take more time as well. So any sense of urgency will be done laparoscopically. And the only other proper contraindication, and I'll go through contraindications in a second for laparoscopic surgery, but any form of bowel dilation. So any obstruction with a bowel dilation of, I think it's something like 3 centimeters, will always be done open. Okay. And I'll talk to you about that, about why. We've talked about some of the reasons already. So elective settings, laparoscopically usually, essentially just a smaller incision, less blood loss, lower infection risk, and they will almost always have less recovery time as well. If there's comorbidities present, then usually operations get done laparoscopically as well. Less complex, again, very operator dependent, but as a rule of thumb, some of the most complex cases will be done open. Okay. So I just wanted to talk to you about that because I feel like on placement, people don't know what laparoscopic surgery is when they first come on and when it's actually done. So most elective case management will be laparoscopic in the sense of general surgery, at least. So some of the actual contraindications where you cannot do laparoscopic surgery, as I said before, hemodynamic instability or shock, simply because of the element of time. So it takes time to set up trocars, set up a camera and go into the abdomen. So this will always be done by a laparotomy. Raised ICP, this is an absolute contraindication as well. So for whatever reason a patient has raised ICP and they also need an abdominal operation, you will never be able to do a laparoscopic operation. And the reason for that is because what you have to do in laparoscopic operations is inflate the abdomen. And what it does is it reduces the venous return back to the head. And this essentially increases the ICP even more. So it's an absolute contraindication. As mentioned before, acute intestinal obstruction with dilated bowel loops, so megacolon in Crohn's, for example, will always be an absolute contraindication. And any uncorrected coagulopathy, simply because bleeding is a lot easier dealt in open surgery than it is in laparoscopic. Okay, so learn these because if you ever see these in an exam question and the question is, should we do it laparoscopically or open? If you see any of these, then it will always be open. Okay. So see, these are some of the common complications of laparoscopic surgery. I wouldn't worry too much about it because it's not that relevant to curriculum. But main things in terms of OSCEs or having to explain to patients why it's an issue is really perforation is a massive risk in laparoscopic surgery. So if you think about inserting trocars into the abdomen, sometimes they're done blindly by some surgeons. And this does work, but there isn't always a risk of perforation during it as well. And I wouldn't worry too much about the vasovagal reactions, etc. But those are the main sort of complications, perforation. So if there's anyone slightly on the younger years here, I wanted to include this slide for you guys because I feel like we see a lot of terms in surgery and we don't really know what they mean. And I'm going to mention some of them today as well. So for the purpose of this session, always learn these for the rest of your placement and the rest of your life because it will make every operation easy to remember. Ectomy will always be removal. Okay, so something like appendicectomy, pancreatectomy will always be a removal of an organ within the viscera. Okay, ostomy is always opening. So something like ileostomy or colostomy. Obviously, if you know the prefix as well, it makes it easier. Otomy, it's usually otomy. I know I've written Tommy, but it's otomy, means incision or cutting into. It's a little bit less relevant, but sometimes you can hear the words such as enterotomy or arteriotomy, and it means cutting an opening into something like a bowel or vessel. Plasty, slightly less common, but essentially repair and reconstruction. So something like abdominoplasty for massive hernias, or mammoplasties for breast reconstruction as well. Scopy, visual examination, I'm sure you're aware, endoscopy, colonoscopy, and pexy means fixation or suspension. So rectopexy, for example, for prolapse. So always try and remember these suffixes because when you learn the prefix, it makes every operation easy to work out, essentially, because there is a lot out there, and it could be quite difficult to go into placement and actually work these out in the first place. Okay, so introduction over. where am I? Yeah. So I'm going to start off with appendicitis because it's genuinely one of the most common things you'll see if you're on general surgery placement or if you're doing exam questions. And it's really not difficult, but there's things to rule out and there's ways to ascertain whether something is appendicitis or not. So we'll go through it anyway. Appendicitis is essentially inflammation of the appendix, as I'm sure most of you are aware. Um, it's usually caused by fecaliths, so pits of feces impacted that got stuck in the appendix, obstruct the lumen, and then essentially cause invasion by surrounding organisms, which can lead to perforation or ischemia. So appendicitis, usually the most giveaway sign of appendicitis will be migratory pain. Okay, so pain that starts off in the periumbilical region, so in the sort of belly button area, and then migrates over the next few hours to the right iliac fossa. Okay, and that's to do with what I was talking about before about visceral and somatic innervation, which I won't bore you with, but essentially. When you see pain migrating down to the right iliac fossa, always think appendicitis. Okay. Along with that, usually patients usually have anorexia, so basically off their food, and have episodes of nausea and vomiting. Plus, can be pyrexia as well. Okay, so these are the things that you should think of when you think appendicitis. Some pretty common exam signs that you'll see. The first one's Robson sign. Now, I've never actually done this before, but essentially it's to do with preferred pain. So if you palpate the left iliac fossa, you'll get pain in the right iliac fossa. Okay, and it's something that really you'll see in exams or potentially get asked in OSCEs, but I wouldn't worry too much about it. Okay. The next sign is psoas sign. So this is only in the context of a retrocecal appendix, which is essentially when the appendix is posterior to the cecum. Yeah. So the cecum's here. And when the appendix is placed posterior to that, this is when we can get psoas sign. So if you ever get a patient to extend their right hip and they have a retrocecal appendix, they will have pain because it stretches the psoas muscle. Okay. It's a slightly niche one, but sometimes it gets asked in exams, etc. Investigations. So, for the purpose of OSCEs, I want you guys to always remember for most general surgery conditions and abdominal conditions, we should always do FBC, CRP, a group and save. Okay, pretty much every abdominal condition, you will have these three things in terms of bloods for OSCEs. Okay, clotting is one thing that can be done if you are anticipating blood loss, etc., or if the person's almost always having surgery. For this case, appendicectomies are almost always done. So you always do a coagulation screen pre-hand for it as well. And as I mentioned before, always do a pregnancy test for young females of fertile age to rule out ectopic pregnancies. Another thing that gets mentioned a lot in abdominal conditions are VBGs. Okay. So the main thing to look at for VBGs is to look for lactate, okay, which is a sign of gut ischemia and anaerobic respiration. When a patient comes in with an acute abdomen and has a high lactate, it almost always means a laparotomy, okay? Because when you have gut ischemia, there's almost no chance of saving it, so it has to be resected. So always do VBG in patients that come in with severe abdominal pain over the last 24 hours. Scanning wise, you can do ultrasounds for appendicitis, but usually clinical diagnosis is fine. Okay, so if you see a sort of young person with right iliac fossa pain, they've been off their food and they're vomiting and have nausea, it's okay to go ahead without doing an ultrasound. But some reasons why would be females coming in with right iliac fossa pain who don't have some other signs of appendicitis, and you want to rule out things like ectopics, ovarian torsion, and ovarian cyst rupture. So sometimes you can do ultrasound, and it's very easy to do in practice for the people that know how to do them at least. And then contrast CT abdomens, rarely done, only if you sort of suspect appendiceal masses or severe perforation. Okay. So to operate or not on appendicitis is a really hotly debated topic over the last sort of 10 to 15 years. People can get better just from using IV antibiotics with appendicitis, but a lot of studies have shown that pretty much a fifth of patients will come back to have their appendix out in 12 months. So as a rule of thumb for exams, always pick the surgical option for appendicitis. Okay. So I've done most of the management section for these conditions as a flowchart just to help. Um, so when we have appendicitis, obviously always needs emergency admission. Okay, so it needs to be seen by a surgical reg. If there's any context of being in the GP, etc., in exams or OSCEs, it will always need to come into hospital to be seen. Okay. And for simple or complicated appendicitis, the gold standard will always be laparoscopic appendicectomy, okay? And plus prophylactic IV antibiotics. And I think I was meant to put in which antibiotic, but I think I've forgotten, so I'm sorry. But usually, as a rule of thumb, broad spectrum antibiotics, something along the lines of comoxiclav and metronidazole will usually be used, okay? So some other situations in appendicitis. When you have a perforation in appendicitis, the main issue will be the main sign, sorry, will be peritonitis. Okay, so as I mentioned before, and this is because when your appendix perforates, the fecal matter goes outside and irritates the peritoneal lining. Okay, so this will almost always mean take it out, wash it out, and give antibiotics in any sense of perforation, be it appendix or bowel. If you have a perforation, it needs to be washed out. Whether it can be done laparoscopically or open is again debated, but for the purpose of your exams, it won't be too important to remember. Just remember that it needs to be washed out and needs IV antibiotics as well. One of the rarer things that you can see are appendiceal masses. So you probably won't see this on placement, but if someone does have an appendiceal mass, be it benign or malignant, if there is no peritonitis, then usually the management is to do an appendicectomy 6 to 8 weeks later. Okay. It's called an interval appendicectomy, and it's simply because operating on a patient with a mass at that time is usually not a smart idea, and leaving it later and just treating with antibiotics is usually a better idea and has better outcomes as well. Okay, so it's pretty simple to manage appendicitis, really. It's usually just laparoscopic appendicectomy, but the main things that I really wanted to mention was how to figure out if someone has appendicitis, especially in women of childbearing age. So main things to remember: migratory pain, rule out pregnancy and UTI, make a clinical diagnosis, but you can use ultrasound if you think otherwise, and always laparoscopic appendicectomy. Okay. If anyone has any questions about anything, just leave them in the chat and then we'll get to them later on. Brilliant. So next condition. So bowel obstruction. This is something you'll see a lot as well on placement and in questions. And it's very simply a mechanical obstruction of your bowel contents. Okay. And usually in exams, you will see a typical patient with very diffuse generalized abdominal pain and an absence of flatus or bowel movement. So absolute constipation is what defines a bowel obstruction. Okay. So if someone's got abdominal pain and they're still passing feces, this technically is not bowel obstruction, it's constipation. Okay. And there's two ways to classify this really, which you'll see. It's small and large bowel obstruction. So small is anywhere from the jejunum to the ileum, and obviously large bowel from the cecum to the sigmoid or rectum as well. And it can be a bit difficult to sort of differentiate between these two. Small bowels almost always in exams will have a history of previous surgery in the last 5 to 10 years. Okay, so the main cause of small bowel obstruction is adhesions. So usually in a stem, you'll see patient had hysterectomy in the last 2 years, and they've now got diffuse abdominal pain with no flatus or bowel movement. And this is almost always small bowel obstruction. Okay. Some of the other reasons are things like hernias, stricturing Crohn's. So not fistulating Crohn's, stricturing Crohn's in younger patients can cause bowel obstructions. And again, in pediatric patients, intussusception as well. And as I mentioned before, it's usually diffuse pain, so all over, and patients will describe a colicky-like pain as well. For people that don't know what colicky means, essentially they'll describe their pain as coming and going, essentially because the proximal colon is squeezing against the food stuck in the colon. And that applies to pretty much any abdominal pain. If it's colicky, or for example, if you have renal colic and your ureters are squeezing against a stone, patients will get waves of pain coming over and over again until it inevitably becomes constant as well. Nausea and vomiting, much more common in small bowel obstructions. So bilious vomiting is quite important. Patients will describe green vomiting coming up as well. And as I said, again, constipation and lack of flatulence, complete obstruction as well. Patients will usually be quite distended on examination, and you'll hear tinkling bowel sounds mentioned quite a lot during examinations, etc. This is probably something that doesn't apply that much clinically, but if you ever see tinkling bowel sounds on an exam, it is always bowel obstruction to an extent. And very importantly, not no bowel sounds, because if someone has no bowel sounds, that means they have something called ileus instead of a bowel obstruction. Okay, so high pitched ringing sort of tinkling sounds can indicate bowel obstruction. Which brings me on to large bowel obstructions. So we said before that small bowel obstructions were usually due to adhesions from surgery. Yeah. When you see large bowel obstructions, it will almost always be because of malignancy. Okay. For the purpose of exams, in reality, about 40% of large bowel obstructions are due to other reasons. But for exams, most large bowel obstructions are due to undiagnosed or diagnosed cancer. Okay. Some other reasons are diverticular disease. Volvulus as well. So sigmoid or cecal volvulus can cause bowel obstruction as well. And it presents quite similar. So the main thing, and that's quite confusing. So the main thing to remember is that vomiting doesn't usually present in large bowel obstruction. Okay. And the only caveat to that is very late obstruction. So to the point where the fecal matter is actually backing up retrospectively up through the colon. It's very rare to get vomiting in large bowel obstruction. And obviously it can be feculent sometimes as well. But usually it's to do with, I won't confuse you too much, but it's to do with the ileocecal valve, which connects the ileum to the cecum. So in most people, it's competent, meaning that poo doesn't go basically back up into your small bowel. So in people with neuromuscular disorders or sort of recurrent inflammation, they can have an incompetent ileocecal valve and can get vomiting sometimes as well. But that's okay. You don't have to worry too much about that anyway. And obviously distension and constipation. But main thing to remember is malignancy for large bowel and adhesions for small bowel. Okay. So for the sake of OSCE, as I said before, always do FBCs. In this context, it will be to look for anemia in the context of malignancy. So if someone's severely anemic with a bowel obstruction, you need to think of malignancy as a cause. I think I'm meant to put U's and E's there. So yeah, FBC, U's and E's for electrolyte disturbances. The reason for this is because essentially when you have an obstruction, the bowel's normal function to absorb fluid gets lost. So all that fluid accumulates proximal to a bowel obstruction, and it can cause really, really severe electrolyte disturbances, which needs to be dealt with immediately, essentially. So, hypokalemia, hypocalcemia, hyponatremia, those sorts of things. So always do use and ease in bowel obstruction. VBG, like I said again, for the same reason of bowel ischemia. So if you think about your bowel being obstructed and twisting on itself for whatever reason, it's very likely to go on and become ischemic, which warrants a laparotomy. So always do VBG in these patients. And amylase. Amylase is a really interesting thing. So anyone with abdominal pain, you should always do an amylase with amylase for just to rule out pancreatitis, because it can present in slightly different regions in clinical practice. So as a good rule of thumb, always mention amylase as your bloods when you're speaking in OSCEs, etc. So imaging wise, this is something that catches people out a lot because it's really difficult to see these x-rays. So I'll give you a few ways to figure out if something's a small or large bowel obstruction, essentially, okay? So essentially, a small bowel obstruction, always think towards the middle of the abdomen. The bowel won't be as dilated as it is in large bowel obstructions, okay? So the rule of thumb is usually 3 centimeters, which isn't really that much on an x-ray. And very importantly, look at the lines going across. So they're called valvulae conniventus, and they go all the way across in small bowel. Okay, which brings me on to large bowel. And you can see the difference here. So it's a lot bigger. It's on the periphery of the colon. And the large colon, if you remember back to your anatomy, you have haustral lines. So haustral lines only go halfway across the colon, which is a really good way to differentiate these two obstructions. Okay. And a good way to remember that is halfway or haustra. So that's the main way to differentiate. Small bowel will be central, lines will go all the way across, and it just won't be as big. Whereas large bowel obstructions can look really massive. Lines only go halfway across, and will usually, and this doesn't always work, but usually it is in the periphery of the picture as well. So abdo X-ray is a good way of doing your initial management, especially with exams. But sorry, guys. But in the sort of first line investigation sense, always need to do a CT abdomen. If you guys just give me 1 second, my laptop's about to run out of charge. Sorry, guys. So yeah, first line is always CT abdomen with contrast as well. Okay, so the main reason for that is a bowel obstruction will always have an underlying cause. Okay, it doesn't just happen. There's always a reason for having a bowel obstruction, and if this bowel obstruction is due to cancer, the patient will need imaging done anyway. Okay, be that for operative planning or to have a diagnosis. So in practice, a CT abdomen is always done a bowel obstruction with contrast. And just as in a point of interest as well, in terms of contrast, contrast is always done to see structures clearly. So things like masses, things like that needs very specific detail, such as arterial problems or sorry, vessel problems will need contrast. So if you want to look anything in detail, as an example, and always do a CT with contrast. And without contrast is usually to look for things like bleeds. So trauma patients or patients that have had a fall and hit their head, you'll do CT head without contrast to look for bleeding. Okay. So management. So you suspect a bowel obstruction. Main thing to do first is to make them know what mouth. It makes sense. They're already obstructed. Don't give them more food. Very simple. And they'll also need surgery. Okay. And this will apply to most general surgery conditions as well. And you'll always get points for saying it. Always make patients nil by mouth if they're having any sort of surgery, but especially GI surgery. Okay. And the main thing to do for most patients, so sorry, all patients that present with bowel obstruction, is to resuscitate them with fluids. And that's because of the reason I mentioned before, of what we call sort of third space volume loss. So a lot of loss of fluid into the intraluminal contents of the bowel. These patients will be severely dehydrated. And by severe, I mean like 4 to 8 liters within a few hours. So always cannulate severe aggressive fluid resuscitation, and then also NG tube insertion. So I put NG tube insertion because what I meant to put was Rolls tube insertion, which is a different form of NG tube. Okay, it has a slightly wider diameter, and in cases of small bowel obstruction, patients will vomit a lot. So to put a Rolls tube down, it always helps them symptomatically as well. So ignore NG tube. I mean Rolls tube. So in the absence of ischemia perforation, and in the absence of any predetermined cause of an obstruction, you'll see drip and suck being used quite a lot for small bowel obstruction. Drip stands for IV fluids, so an IV drip to replace the fluid loss, and suck essentially from the Rolls tube. You can aspirate air and decompress the small bowel. Okay. And this only works for small bowel obstructions. And that's because of something that I talked about earlier, because of ileocecal valve competence. Okay. So if you think about the valve, if it connects the large and small bowel, if you try and aspirate from the mouth, it won't reach the large bowel. So it only works for small bowel obstruction. Okay. Analgesia, antiemetics, always just think about symptoms per patients. It'll get you points in OSCEs, it'll make you a good doctor. These patients will be in severe pain and will always be feeling nauseous. So always use analgesia and antiemetics. And very importantly, use something like cyclizine. And the reason I say this is because there have been incidents in the past where people have used antiemetics like metoclopramide, which are prokinetics. And these genuinely just worsen the obstruction and can lead to perforation very easily. So you always use something like an osmotic antiemetic like cyclizine for bowel obstruction. Some other scenarios, so ischemia perforation, like I said before, always IV antibiotics and call they'll always need an emergency laparotomy, okay? To look for viable bowel, wash the abdomen out, and is essentially just safer for patients. So the third patient cohort in this is people that actually aren't suitable for surgery, okay? And these do tend to be people who have a lot of comorbidities or have metastatic cancer. So usually the questions then will have something like patient presents with, an unknown stage 4 colorectal cancer. They present with a bowel obstruction. What do we do? Well, we can't take them for surgery because they'll pretty much die in theatre guaranteed. So what we need to do is always address the symptoms. So the best thing to do for these patients is to insert what we call a SEMS, and it stands for self-expanding metallic stent, and it essentially just it does what it says on the packet. It just keeps the bowel open for symptomatic relief and obstruction. And this can either be palliative, so to support patients in their sort of last days, or as a bridge to surgery. So if a patient isn't well enough for surgery there and then it can be a really good bridge to sort of bring them to that optimum level for surgery as well. Okay. So most important things to remember: nil by mouth, always fluid resuscitation and Ralph's tube insertion, and then treat the cause. So we'll come on to some of the causes, some specific scenarios now. These are some very specific scenarios. So if a patient is healthy and needs bowel cutting out, then usually what gets done is what we call a segmental resection, plus or minus a primary anastomosis. So segmental resection is taking blocks of colon out, and primary anastomosis means joining the two ends that are left back together there and then at the surgery. And we can only do this for sort of young patients with no other diseases because the healing of anastomosis in surgery is it's a really big debated topic, but essentially the younger you are, the easier it is for an anastomosis to heal. And there's a few other factors like anatomical location, which I won't go into. And hopefully we'll be done in colorectal next week. But essentially the more proximal you are, the easier it is to do primary anastomosis. Okay. If someone has a cancer, it will pretty much always be a sigmoid malignancy. And the operation that gets done for this is a Hartmann's procedure with ankylostommy, which you might see or hear of quite a lot. And it's essentially just a sigmoidectomy and removal of the upper rectum, which gets done only in emergency settings. So they take this section out and then essentially bring out the end of the colon to cause to form an end colostomy. The end of the rectal stump gets sewn back in, as you can see on the picture on the right. And this can be reversed later on as well. But this is usually an answer option, usually for large bowel obstruction with anyone with malignancy. And because sigmoid is one of the most common areas of colon cancer, we'll always have a Hartmann's procedure. Okay. Another reason for obstruction would be something like multisynchronous tumors, so tumors that are located around, slightly rarer, but it can happen. But something more common is something like megacolon. So in something like ulcerative colitis, if the patient gets megacolon, bowel obstruction, and then perforation, they usually end up having a subtotal colectomy. Subtotal colectomy means from the cecum, I don't know if you guys can see my mouse actually, but from the cecum all the way to the sigmoid, the rectal stump gets sewn back in and patients are left with end ileostomies. Okay. So essentially a stoma bag for the rest of their life. So that's done in Crohn's disease. And then if there's a small bowel obstruction and they have a lot of adhesions, then we'll do adhesiolysis, which is just division of the adhesions. Okay. I talked a bit about stomas. As I said, a stoma usually gets made at the first surgery if it's unsafe to make an anastomosis, be it from emergency surgery or if, for example, you're doing rectal operations, they almost never have stomas done at primary surgery and have it done later. Elderly patients and anatomical need. But again, hopefully it gets discussed in colorectal next week. I won't go into it too much. And this is just a picture of a laparotomy, just for reference. So key tips, diffuse abdominal pain in the absence of bowel movement, always think bowel obstruction. House draw halfway is a lifesaver because you see abdominal x-rays and you don't know what's going on. Essentially, if the lines aren't going all the way across and it looks massive, always think large bowel obstruction, okay? Fluid resuscitation will always be a thing, and management will depend on what the actual underlying cause is, okay? So acute pancreatitis. It's not technically not a surgical emergency, but it comes under general surgery, and it's quite common. So I'll go through it anyway. And it's essentially just inflammation of the pancreas. Always presents with something along the lines of severe epigastric pain radiating to the back. Okay, so if you ever see pain radiating to the back, always think pancreatitis. It's usually accompanied with nausea and vomiting, epigastric tenderness, ileus, and I'll explain why patients can get ileus in a second. Fever, usually if there's an infective cause, and then something that a lot of you guys have probably seen a lot, but Gray Turners and Cullen sign. These are really late signs of pancreatitis. So this is what happens in something what we call hemorrhagic pancreatitis. So in reality, if you see these signs on a patient, it's usually a very late stage presentation. So you probably won't see it, but it's a good thing to remember for your exam prep anyway. The most important thing to remember with epigastric or central abdominal pain going to the back is always triple A rupture. Okay. And if you guys have done any vascular surgery, you understand that this is genuinely one of the biggest emergencies in medicine. So in an OSCE setting, you should always say rule out a triple A rupture because this will present very similar to pancreatitis. This usually presents with severe pain going to the back and hemodynamic instability, which pancreatitis can present with as well. So always rule it out, be it with ultrasound or CT scan as well. Okay. I'm sure you guys have seen this before. Best way to remember it, I get smashed. Main causes of pancreatitis. So iatrogenic, usually through surgery or ERCP. Gallstones, by far the most common cause. So 50% of pancreatitis is gallstones related. So essentially gallstones going back through the pancreatic duct and causing obstruction. Trauma can cause pancreatitis, especially sort of blunt force trauma to the abdomen through car crashes can cause pancreatitis quite easily. Steroids, mumps, some slightly niche conditions like Sjogren's and SLE, scorpion venom, which Passmed loves, hypercalcemia, ERCP, and some drugs like azathioprine and NSAIDs, and some diuretics as well. But main thing to remember is basically gallstones and alcohol are the two main culprits. So 75% of the pancreatitis cases are due to these two things, and all the others sort of come in tandem after. Okay. So it's like appendicitis. You can make a clinical diagnosis if they have characteristic pain and you've done an amylase already, okay, as I've mentioned before. So the amylase needs to be 3 times the upper limit. Amylase it's sensitive to pancreatitis, but it's not necessarily the most specific. Okay, so it can get raised in other things such as small bowel obstruction as well. So it needs to be 3 times the upper limit for it to be diagnostic of pancreatitis. Ultrasound for pancreatitis is only done if there's an uncertain clinical pictures. Okay, so it will be the first line imaging if you can't ascertain whether something's pancreatitis or not. But essentially, that is the first scan to do. And then you can go on to do a contrast CT. And this is really only if they're extremely unwell. Okay, so I'm talking like hypertension, septic, unwell, is when they need contrast CTs. But it can also be quite good to look for complications as well, such as pseudocysts, etc. And there's a little picture of pancreatitis. I can't see anything, to be honest. I don't know if you guys can, but essentially it just shows the thickened pancreatic wall. So sorry for the really bad picture, but this is the best one I could find of the mnemonic. But this is the best way to risk stratify pancreatitis on the ward and in exams. And the mnemonic's really easy. It's just pancreas. Yeah. So the reason I mention this is because when you learn this, you know exactly what investigations to ask for, basically, because it's a really good way to monitor pancreatitis. So it's called the Glasgow score. Um, Essentially, oxygen partial pressure, age, neutrophils, calcium, urea, LDH, albumin, and sugar. Okay. And you can use MedCalc for this if you're on the ward. Have a go at it. And it usually gets done on admission and 2 days after to monitor, firstly, ascertain how bad the pancreatitis is and how well it's getting better. So when you've learned this, then you can learn, you can remember what investigations to do. Okay. Because some things are pretty random. So things like, as it's written here, cap blood glucose. Hypoglycemia does indicate severe pancreatitis. Even though hypoglycemia is a cause, hyperglycemia has severe pancreatitis. So always do cap blood glucose in these patients. ABG for risk stratification for partial oxygen pressure, and like I'll always say, lactate. Always do lactate. ECG. So this brings me back to when I mentioned medical causes of abdominal pain. Any upper abdominal pain, always do ECG or plus minus chest X-ray to look for signs of ACS or pneumonia. Pregnancy test is a bit of a stretch. I don't know why I wrote that, but just to push the push the point. And then bloods wise, as I've said before, FBC, CRP, using these. LFTs will usually be quite deranged in pancreatitis. So you usually see patients with quite a high ALT and bilirubin, but don't necessarily give you a diagnosis as such. LDH for risk stratification, bone profile for calcium, blood cultures if you're suspecting an infective cause, coagulation, obviously, and a lipid profile, again, for the Glasgow score. Okay, so just remember these things for OSCEs. You don't need to remember all of them. They're just really good things to say when an examiner asks you, what would you do next? And you already know the Glasgow score. So management, always treat the underlying cause with bowel obstruction, and there's always an underlying cause. It doesn't just get inflamed for no reason. So you need to figure out what's actually causing the pancreatitis. Okay. But as a general rule of thumb, these patients always need to be catheterized, okay, because they can go septic very easily, and you need to monitor their urine output very accurately. And the best way to do that is to put a catheter in. Okay. So always put a catheter in these patients. These patients will always be in severe pain. So IV opioids are always needed. So something like not Oromorph, IV morphine usually needs to be used. And usually especially with severe pancreatitis, usually needs some sort of critical care input as well. So contact the senior, basically call for help. But in terms of uncomplicated pancreatitis, a lot of people think, obviously, because it comes under general surgery, that it's a surgical condition, but it's really not. And the main thing to do is to just treat it supportively. So aggressive fluid resuscitation, and it's like bowel obstruction. There's a lot of third space volume loss. So more than 5 liters of volume loss, pretty much in a day. So resuscitate them with a crystalloid, so something like Hartmann's solution. And essentially they need a bed to be monitored for severity and any complications. Okay. So any patient with severe vomiting and pancreatitis, essentially do the same things, but this time antiemetic, so cyclizine. I love cyclizine. Keep them nil by mouth. So if they need any surgery in the future, and a Rolls tube insertion, only if they're vomiting severely. So never put NG tubes in patients that aren't vomiting. Okay, it goes against their comfortability. It's a very nasty thing to put in, and you can usually keep people sort of 72 hours without essentially feeding them if you need to. But putting an NG tube really is not the right step if they're not severely vomiting. So that's what you do with severe vomiting. And then with very severe necrotizing or infected pancreatitis, these patients will always need antibiotics. Okay. So the ones before were pancreatitis without an infective cause and were inflammatory conditions. So never ever say IV antibiotics for simple pancreatitis. It will always be treated with fluid. But for any infected or necrotizing pancreatitis, they all need very strong IV antibiotics. Okay. Fluid resuscitation, like we said, and always need a consultant review. And most of these will need a consultant review anyway, but if there's any condition that needs it, it's necrotizing pancreatitis because it's it's not very easy to operate on, and it very rarely gets operated on because when it does, it has a very high morbidity rate. So always need to consult and review. Okay. So some specific scenarios. Gallstone pancreatitis, very common. Always needs an elective lap chole at some point. And I'll talk about lap chole in a second, sorry, for those that don't know. But electively, we'll need a lap chole and an ERCP. So an endoscopic retrograde cholangiopancreatography. I think I got that right. Essentially just the tube inserted through the mouth, going all the way down, takes the stone out of the pancreatic duct, okay? Necrotizing pancreatitis is really difficult to deal with. You won't see it much in exams, but if you ever see a question on it, it usually gets done with radiological drainage because it's really hard to do surgery in these patients, like I said. So usually through a cannula, through the stomach, gets drained just for symptomatic relief. And any drainage of contents such as pus, etc. You can do things like surgical necrosectomies. It's done endoscopically and essentially goes through the posterior gastric wall to resect any necrotic material, but it has a very, very high mortality rate. So it's a bit niche, but it can be done. And anything hypertriglyceride induced can be dealt with IV insulin infusion. Okay. So as I said, very rarely operated on, has a really high morbidity. Probably should be managed by medics, but it's political, so it comes under general surgery. So main things to remember: epigastric pain coming to the back. Always rule out AAA by ultrasound. Amylase needs to be 3 times upper limit. It doesn't just need to be raised; it needs to be 3 times the upper limit. And don't give IV antibiotics to everyone. If we gave IV antibiotics to absolutely everyone with pancreatitis, we'd have horrific resistance. So only with infected or necrotizing pancreatitis, and only in severe cases do we use surgical management. Okay. Sorry, I've loaded you guys with a lot there, but we'll keep it pushing because we are actually kind of short of time. And we'll go on to cholecystitis. So the main thing that used to confuse me on third year placement was these 2 words, yeah. And I'd absolutely hate seeing them because I didn't know what they meant. So I'm going to go through them now. And if you look on the right side, this essentially explains anything going on in the right upper quadrant. So chole always means something to do with bile, gallbladder, bile duct, okay, as a prefix. Itis, inflammation, okay. Lithiasis means calculi formation, and docholithiasis means calculi formation in the tubules, okay. So if we take that knowledge and apply it to the left, cholelithiasis means stones in the gallbladder. Choledocholithiasis means stones in the CVD, okay? And I probably should have a picture of the anatomy there, but I didn't. But anyway, so cholelithiasis, stones in the gallbladder, gets infected, cholecystitis, okay? Whereas when they're in the bile duct and it gets infected and inflamed, cholangitis, okay? 2 very different conditions. Cholangitis is managed medically, cholecystitis is managed surgically. So we'll go through cholecystitis now, but I hope that sort of makes sense. Always remember your prefixes and suffixes. So inflammation of the gallbladder, inflammation plus minus infection, usually in a stem of constant right upper quadrant pain with a fever in a sort of obese middle-aged lady. So if you ever see right upper quadrant pain with fever, always think cholecystitis. The main sign from this is Murphy's sign. So when you palpate the right upper quadrant, that shouldn't say pain when inspiring. Essentially, they'll stop breathing momentarily because it's so painful. So you essentially, when you're doing palpation like you do for sort of hepatomegaly, if you do the same thing in the right upper quadrant and the patient suddenly goes like that, that's Murphy's sign. And it's a really strong indicator of cholecystitis. Guarding and rebound tenderness only when it's a late presentation. So peritonitis, basically. And this is a good way of remembering it. 4 Fs. So fat female. Oh, I've gone off it. Anyway, fat female, 40 and fertile. So obese women, middle-aged, of childbearing age, usually are what present with cholecystitis. And the reason I say obese is usually because most gallstones are cholesterol formed. Okay, so about 90% are cholesterol. So you'll see it a lot with people who have hypertriglyceridemia. Main things to do investigation-wise. again, with any general surgery condition, as I said, FBC, CRP, LFTs, ALT will normally be a bit raised, but bilirubin will normally be normal unless they have Maritzi syndrome, which I won't go into, but very basically, it's essentially extrinsic compression of the common bile duct from the cystic duct, but it's quite niche. Always do amylase with upper abdominal pain, and urine dip again, a bit of a stretch because it's quite high up, but it's very easy to do. And you can miss things like UTIs that can go really far up as well. First line is ultrasound. So what we're looking for, as you can see on the picture, is the little dots that you can see. So the actual gallstones, gallbladder wall thickening, bile duct dilatation, and the presence of pericholecystic fluid. Okay, so essentially it's obstructed, inflamed, which has led to a leaky wall and fluid is accumulated outside. But don't worry too much about the ultrasound report anyway. If that's inconclusive, what we can do is something called an MRCP. And it's very similar to what I mentioned before, like an ERCP, essentially, but it's just not, you can't treat anything with it. So it's just a scan and it sends a dye through retrograde through the biliary tree to see if there's any obstruction. But it's usually done in cholangitis and CBD obstruction. So it's only if there's absolute inconclusive evidence that there's cholecystitis. Okay, so ultrasound first line and MRCP second line if needed. So sorry, I've done my animation horrible there. But anyway, acute cholecystitis, main thing, pain relief, antiemetics, keep them nil by mouth. Always remember those three things. I'll keep saying it because if you say them, you'll always get some sort of points in abdominal pathology. Okay. And usually in uncomplicated cholecystitis, we'll give IV antibiotics and do a lap chole. So this should ideally be done in 72 hours, but in reality, in our hospitals, they're done in about a week. Okay, so it's not that urgent if they're treated with IV antibiotics, but for uncomplicated cholecystitis, it needs to be done in a week for the purpose of exams, but clinically should be done in 72 hours. Okay. So the other situation is someone who's got cholecystitis and isn't suitable for surgery. So this can be due to comorbidities, malignancy, etc. And what we can do for them, and I'll show you a picture later, but you essentially give them IV antibiotics and do something called a percutaneous cholecystostomy. Okay. And if you remember when I went through suffixes, ostomy means opening. So essentially just a drain through the abdominal wall to drain bile and treat the infection with IV antibiotics. It's not definitive, it's just done for symptomatic relief. But if you ever see very frail patients that can't undergo surgery, then the gold standard is percutaneous cholecystostomy, which is done by interventional radiology. The other third scenario is if it's improved, but the inflammation's still there. So some patients you can delay it quite a while, so about 6 weeks, and it's called a hot lap chole. So these can usually get organized later on to be done electively. But essentially, if it's gotten better, but there's still some inflammatory markers there, then you can do a lap chole in 6 weeks. So just a picture of lap choles because we always see it, we always hear about it. We don't know what's going on, and it's literally just taking the gallbladder out through a laparoscopic operation. And this is a picture of a cholecystostomy. Okay, so a tube draining the bile for symptomatic relief. So main things to remember, constant right upper quadrant pain with fever will be cholecystitis. There is a few other causes of right upper quadrant pain, which unfortunately I didn't have the time to go through, but if you ever see constant pain, then it will be cholecystitis. Always do amylase and do the lap chole in a week. And then for symptomatic relief, you can do cholecystostomies, okay? So apologies because these are really, really bad slides, yeah. But I wanted to go quickly through hernias because they come up a lot and there's some confusing things in them. So I'm not going to go through every hernia, but I'll try and whiz through sort of the main ones and what to remember. Okay. So a hernia is a protrusion of an organ through the abdominal wall, usually due to weakness. So either due to old age, connective tissue disorders, or previous surgery. And it's a really common thing. You'll see it on placement all the time. And the best thing to do is just memorize where each one is. Okay, so we have epigastric hernias in the epigastric region, umbilical hernias, and then inguinal and femoral hernias, which are a bit more difficult, but I'll tell you a good way to remember them in a second. Main signs and symptoms, they'll have a lump, a really superficial lump, and usually when you get them to cough, it will bulge out even more due to the increased abdominal pressure. And then we'll see these two terms get used, or you'll see them in placement quite a lot. So strangulated or incarcerated. I'll go through them in a second, but essentially, if they're strangulated or incarcerated, there will be severe pain over the site. Okay, redness, pain out of proportion essentially because the hernia is being compressed essentially. Um, but I'll explain what strangulated and incarcerated mean in a second. So most hernias are inguinal. Okay, so 75% of hernias are inguinal, and most of those are male patients as well. Okay, so in practice, you will pretty much only see inguinal hernias, the remaining being femoral and umbilical hernias, and then some post-op incisional hernias that you can get as well. Femoral hernias are a bit more common in women, but rarer overall. And then incisional hernias you'll see with post-op patients, like I said, after laparotomies, and big incisions where they've essentially not sutured well enough, or sometimes they have structural defects that can cause the abdominal contents to herniate through. Okay. And you can also get things like sort of laparoscopic site and hernias, etc. There's a lot of niche hernias that you don't need to worry about. But the three main that I would remember would be inguinal, femoral, and for umbilical and incisional. Okay. So groin hernias. The main thing to remember is the location of these two because it comes up in questions a lot. So inguinal will always be superomedial to the pubic tubercle. Okay, so towards the midline. And if you try and palpate a patient on their pubic tubercle, if it's above and towards the midline, that's an inguinal hernia unless proven otherwise. Okay, whereas a femoral hernia will be inferior lateral to the pubic tubercle, and that is genuinely the best way to ascertain whether something's an inguinal or a femoral hernia in the groin. The reason this is important because inguinal hernias aren't as prone to strangulation as femoral hernias. Okay, and it's essentially just to do with the femoral ring being extremely tight. So when abdominal contents go through femoral rings, they're always tightly squeezed, and it can lead to strangulation very urgently. So these patients always need to be sent for surgery quickly, whereas inguinal hernias can be done electively over the next few weeks or months, etc. And management-wise, for inguinal hernias, interestingly, if it's unilateral, it will be done openly with a mesh repair. Okay. Whereas if it's bilateral, you'll do it laparoscopically. And I'll explain why. So if you think about having two inguinal hernias on each side, if you try and do it openly on both sides, you'll either have to do a massive incision or do two incisions on both sides, yeah? Whereas if you do it laparoscopically, you can rotate your camera around and do both at the same time. Yeah? Really simple. And then femoral hernia is either done laparoscopically or, to be honest, a lot of them end up strangulating. So laparotomy, which I'll talk about in a second. So another really confusing thing, direct and indirect inguinal hernias. So direct means the way I think of it is literally perpendicular, directly out the abdomen. Okay, so it hits the posterior wall and doesn't go through the inguinal the inguinal canal. So these will actually protrude through the abdomen and you'll see them as a palpable lump. Whereas indirect hernias go through the inguinal canal and will go into the scrotum as well. Okay. So usually they won't protrude when you see them, and when people cough as well, they'll instead go through the scrotum and you'll see it in the scrotum instead. So the best way I think of it is just direct, perpendicular out to the abdomen is one that's just affecting the posterior wall. Okay. And surgically, the only way to differentiate it is that direct inguinal hernias are medial to inferior epigastric vessels, whereas indirect are lateral. But I wouldn't worry too much about that. But mainly, most of them are indirect with younger patients, so about 80%, and they're usually due to congenital wall defects, so rings that haven't closed up over time. And older patients tend to have direct inguinal hernias. Okay. So, some quick terminology. So, if a hernia is irreducible and you can't push it in on a patient, That means it's incarcerated. Okay. So if you think of it as a person going to prison, you get incarcerated first. Yeah. You go to prison. The hernia then progresses to become strangulated. So that means you can't push it in. And there's also evidence of loss of blood supply. So things like pallor, severe pain, and loss of tissue on the surface indicates strangulated hernia. So if you go palpate, I don't know if any of you have palpated a strangulated hernia before, but it will genuinely cause agony to the patient because there's bowel ischemia going on. So the way I think of it is incarcerated means you've gone to prison and then you get strangled by an inmate. Simple as that. Okay. It goes on and it progresses. And strangulated hernias are always an emergency that needs to be dealt with immediately. So pretty much always will need an emergency laparotomy, and either sort of observation for bowel viability. So if the bowel's died, then it needs to be resected like it was before, or sometimes they can be just repaired with a mesh as well. Okay. So this is just a little diagram. It's actually a bit confusing to be honest, but just remember what I said before about laparoscopic or open repairs to inguinal hernias. Okay, if it's bilateral, think of the camera going to both sides. It will be laparoscopic, and if it's unilateral, then open repair. Females usually tend to get laparoscopic surgery because they have an increased risk of femoral hernias and an increased risk of chronic pain as well. So usually we'll get done laparoscopically. And the main treatment for any hernia repair pretty much will be mesh repair. Okay, so just go in, put a sort of titanium mesh around the defect to prevent it from coming out, and then prevent any protrusion of abdominal contents as well. Okay, so that's a little whiz through of hernias. There is a bit more niche things to it as well, but those are the main things that sort of used to confuse me when I was back in third year. So main things to remember: palpable, superficial lump are hernias. Inguinal, supromedial, and femoral is inferolateral. Okay. It starts off incarcerated and then becomes strangulated. And then after that, you can either repair with a mesh or do a laparotomy and assess for bowel viability. Okay. So I've tried to whiz through as much as I could, to be honest. We've actually done pretty well on time, but those are the main general surgery emergencies that you can do, that you have to deal with on placement and in exams. There's a lot more to GI pathology. So the colorectal session next week will cover some other things as well, but these are the main things you'll see on in GI at least for surgery. So thanks for coming. We've got a little form here for feedback. Would be great if you guys could do it. Just scan it and do it, and then leave any feedback you'd like, anything you didn't like as well, so I can improve for next time. And does anyone have any questions at all?
Again, about the aggressive fluid resus for bowel obstruction.
Yeah, I can. Fluids. I can't even go back on these slides, you know. So third space volume loss. Yeah. So when you have an obstruction, the food is basically, or whether it's impacted, the bowel squeezing behind it. In that space, the fluid accumulates because it can't get absorbed further on, essentially. So yeah, and there's a few more things to it, but essentially the body starts secreting other hormones to increase electrolyte secretion into the bowel. So you lose it from your cells into the lumen of the bowel, which leads you to get like hypercalcemia. So you need to treat them really aggressively with crystalloids to replace the electrolytes, essentially. Same with pancreatitis, because people go into shock, get hypertensive and lose fluids. So with both things, just treat them with really, really quick fluid resuscitation. Third space volume loss. Yeah, and shock. So systemic inflammatory response syndrome. Do you remember? SIRS. But yeah, these patients will get really hypertensive and lose all of their souls. So yeah. Mersey syndrome. So sometimes you can get a stone in the cystic duct, and it can actually obstruct so much that it compresses either the common bile duct or the hepatic duct from the outside. Does that make sense? And it's really misleading because you think people have cholangitis, but it's just a stone compressing from the outside. It's really rare. It comes up sometimes. But essentially that bilirubin will go up. Yeah.
Okay.
'Cause-
Good.
Whereas in cholestasis, it won't. Brilliant. No worries. Well, if everyone's done, thanks so much for coming. Do come to the next ones. And don't slate me too much on the feedback. Thank you very much. Cheers, guys.